In a journey of young ophthalmologists, becoming a trustworthy and confident cataract surgeon is always what we wish to be. When we encounter the patient with aphakia, what are the choices of intraocular lens that we can offer to our patients? Whether it is anterior chamber intraocular lens, retropupillary iris fixated intraocular lens, or sclera fixated intraocular lens. Complications of anterior chamber lens are well studied throughout the times. One of the most common complications is endothelial cell loss. Retropupillary iris fixated intraocular lens is a good alternative of choice as it can be performed without much difficulty. On the other hand, sclera fixated intraocular lens is more challenging, especially for the young ophthalmologists. Various complications that arise from the sclera fixated intraocular lens can be a discouraging factor for the young ophthalmologist who wishes to proceed. In 1991, Dr. Lewis proposed the sclera fixation technique with the sclera flaps and ab-asteral suture. In 2007, Dr. Sharoff first described the sutureless intrascleral fixation of the intraocular lens. In 2008, Dr. Akawa introduced the usage of fibrin glue application to the sclera flap for sclera fixated intraocular lens. In 2017, Dr. Yamane published a sutureless transconjunctival intrascleral fixation technique with the elegant double needle technique. In 2019, Dr. Ciego Canabrava proposed a sutureless sclera fixation technique named the 4-flange technique with no flap, no knots, and no glue. These are the simplified steps for the 4-flange technique. Step 1. Insert the needle from the sclera into the eye, then thread the suture into the needle. Step 2. Repeat the same procedure at the opposite side. Step 3. Insert the suture into the eyelid of the haptic, then make the first flange. Step 4. Insert another suture into the other eyelid of the haptic, then make the second flange. Step 5. Insert the intraocular lens into the eye and center it with the proline. Step 6. Cut the suture and make the third flange. Step 7. Cut the other end of the suture and make the fourth flange. In this video, I'm demonstrating some simple modification to ease the process of 4-flange sclera fixation technique. In the original 4-flange sclera fixation technique, the sclerotomy measure 2 mm from the limbus is performed. Then the proline suture is inserted into the 26-gauge needle with the help of the microforceps. In my case, I am demonstrating preloaded proline 5/0 suture into the 27-gauge needle. The same procedure is repeated on the other side. Anterior vitrectomy is then performed to remove any residual vitreous in the anterior chamber. Subsequently, ophthalmic viscosurgical device (OVD) is injected into the anterior chamber. A 27-gauge needle with preloaded proline 5/0 suture is checked properly to ensure suture in place. A sclerotomy measure 2 mm from the limbus is made at one side using this 27-gauge needle. The preloaded suture is then advanced slowly until the suture is visible. The microforceps is then used to grasp the suture and exteriorize it. As you can notice, the eyeball is soft during the first sclerotomy. OVD is further injected into the anterior chamber to keep the eye firm. Second sclerotomy is performed in the opposite side with similar method with much more ease after filling in adequate OVD. Here comes the beautiful fencing duel in the eye. Suture is then passed through haptic eyelid and first flange is created using portable cautery. Insert the other suture's end into the other eyelid and make a second flange. Both flanges are tested individually for their steadiness and stability. It is an important step to ensure the flanges do not slip through the eyelet of the lens. The intraocular lens is then inserted into the anterior chamber with the help of the forceps. Intraocular lens is then centered via the adjustment of the Prolene sutures at both sides. Once the intraocular lens is in place, remove the excessive Prolene suture at the base and make the third flange. Similar procedure is repeated on the other side and make the fourth flange. The flanges are then buried under the conjunctiva. Is this a safe technique? Recent study published in this year in Journal of Cataract and Refractive Surgery shows that this is a safe technique with short learning curve, satisfactory vision outcome, and stable intraocular lens position. However, more data are needed. What are the learning points from this case? I have found that this technique is easier to master, especially for the young ophthalmologists. With this modification, preloaded suture performed outside the eye can be more convenient and easier for the young ophthalmologist to handle, as the original maneuver is performed inside the eye. This technique is useful, especially in certain cases when the cornea view is poor. The extra point I have learned from this case to make sure the eyeball is firm enough, either with the help of the OVD or NC maintainer, so that the sclerotomy can be performed easily. Modified four-flange sclerafixation technique is no doubt an excellent technique which provides a great alternative for sclerafixation, especially for the young ophthalmologists. My special thanks to all the great ophthalmologists out there for their sharing, creativity, and encouragement, giving me the guidance and light which made the journey of young ophthalmologists easier and colorful. Thank you for watching.